capacity to consent framework. So my name is Sean Treweek, and I'm a health services researcher at the University of Aberdeen. I'm very interested in how we improve inclusion within trials. And we have a distinguished panel with us today. So firstly, alongside me, we have Professor Paul Dark, who's Deputy Medical Director of the NIHR Clinical Research Network, also the Chair of Critical Care Medicine at the University of Manchester, an Honorary Clinical Consultant at Northern Care Alliance NHS Foundation Trust. And next to Paul, we have Dr. Vicky Shepherd, who's a Senior Research Fellow at the Centre for Trials Research at Cardiff University, where Vicky leads a programme of research around trials involving adults with impaired capacity to consent, including a project called Consult, and Vicky led the development of the framework that we're going to be hearing about today. So what you'll hear a couple of talks, one from Paul, one from Vicky. So Paul will talk about the NIHR Equality, Diversity and Inclusion strategy and how tools such as the framework can help to improve the aims of NIHR with regard to inclusivity in research. And then Vicky will explain the background to the Impaired Capacity to Consent framework and how and when you'll be able to use it. We will have lots of time for questions, and we would love your questions. It's always a really great part of sessions like this. So we're hoping we'll have around about 20-25 minutes for questions. If you do have a question, you'll probably have noticed at the bottom, we have a Q&A button. If you put your questions into the Q&A, then I'll handle those when they come in. Okay, so 20 minutes of talk from Paul and Vicky, and then we'll probably have 20-25 minutes of Q&A, so plenty of time for questions. We will be recording, you've probably already seen that or heard the little message, and that recording will be available pretty much immediately after the talk. So sometime today, we anticipate that recording will be available to you and colleagues who were not able to join today. And I can now see from participants, we have a very large group of people. So it's currently 180 odd people. So this is a really popular topic today. So thank you for spending your time with us. Before we get into the talks, we want to do a couple of polls. And these polls are just to give us a bit of an idea of who's in the audience, and then a little bit about your how aware you are of this particular topic. So we'll start with the first poll, and this is about what best describes your role. And some of you might look at that and think, well, there are 2 or 3 of those you could tick. If you just choose the one that best describes your role, bearing in mind there might be others, but what best describes your role? And we'll give that about a minute to allow people to vote. Hopefully it's not too tricky a question for people to make their choice. Okay, so I'm gonna count down to another 5 seconds or so. I'm gonna close the poll and we can see who is in the session. Okay, so 5, there we are. Right, so let's see. Hopefully we'll be able to see who's in the session. So most people who are in the audience are researchers, so somebody like me, for example, but we have a good mix of other people too. So mostly researchers, but we do have other individuals in the audience too. So thanks for doing that. So that gives us a good indication. Now, the next poll is just to get a sense for how aware you think you are of the topic, this idea of impaired capacity to consent right now, on a scale of 1 to 10. So if we see this poll come up, and then you basically answer the question, out of 10, how aware do you feel about the topic, this impaired capacity to consent, prior to now? So what's your baseline knowledge? So again, we'll just use a few seconds to make a choice on that score of 1 to 10. And I guess if we're basically scoring 1, we don't know very much at all. And if we're scoring 10, we're Vicky and Paul. Okay. So we'll close that in about another 5 or 6 seconds. And then let's see how much knowledge we have in our group today. All right, so quite a mix there. Some knowledge, but it's certainly not we're all very well informed. So hopefully at the end of the session, we'll come back to this poll. At the end of the session, let's see if we've got a shift. But I guess we're all here, and I'd certainly include myself in this. We're all here to learn today. There's plenty of opportunity for us to shift up from the low end of that scale to the higher scale. Okay, so that is fantastic. So hopefully you've got a basic idea of what we're going to talk about today. And as I said, we'll come back to that poll at the end. So now we'll start with the actual talk. So if I can hand over to Paul, please.
Thank you, Sean. I'll just share my screen and get cracking on my presentation. So can you hear me okay and see my slides?
Yep, that's looking great, Paul. Thanks.
So the first thing to say is to thank Sean and Vicky and the organising committee for an invitation to take part in today. As Sean has said, I'm a researcher and practicing critical care physician. So the subject matter here is very interesting to me, and I'm really pleased to be here to learn as well. But my main duty for the first 10 minutes is to talk through the importance of this subject area more broadly to the NIHR in my role as Deputy Medical Director. And to enable me to do that well, we work very closely with Dr. Esther Makuka, who leads a cross NIHR program of work, a very ambitious program of work around equality, diversity, and inclusion. And she has led, and it was launched last month, a strategy on this for the next 5 years. So I'm going to allude to that briefly and then talk about the Include program and how the very important work that you're going to hear about today fits into a broader mission. So I guess the first thing to say, as an organisation at the NIHR, we have a very clear context that has been identified in Best Research for Best Health. Most of you will be familiar with that. If not, there is a link to that document at the bottom. And NIHR's mission is stated to improve the health and wealth of the nation through research, but I've actually included here more inclusive research. So including patients and the public who are most likely to benefit from interventions in studies is crucially important. It's ethically necessary, it's scientifically sensible, and is going to produce enormous value to the resources that we use in research and within public services. So this is absolutely crucial, and it does link directly into government strategy for economic growth. So the things that we're going to talk about today actually are cross-cutting across systems, so not just isolated to health and social care. So I'm going to read one of our most important operating principles at the NIHR that we've written down. I'm going to read it out to you because I think it is really important that we all get behind this. So we are committed at the NIHR, we share this commitment with you to equality, diversity, and inclusion in everything that we do. Diverse people and communities shape our research, and we strive to make opportunities to participate in research an integral part of everyone's experience of health and social care services. We develop researchers from multiple disciplines, specialisms, and geographies and backgrounds, and work to address barriers to career progression arising from characteristics such as sex, race, and disability. So yes, it's about the research we do, but yes, it is also about the community of researchers and the broader people policy that we have, and making sure that diversity is part of all of our mission. And so we have very clear aims set out in Esther's diversity strategy, and there's a link to it at the bottom here, which you can look at later on. So our aim is to deliver an EDI policy across our entire people framework. So we're talking about our own workforce, our research workforce that we support, advisory groups in terms of people that make decisions about funding, our panels, research participants, which is very much the focus of today, and the public more generally. And we've got to embed this into everything that we do. So we have 5 strategic themes. I'm not going to go through all of these, and you would expect to meet our aims that there are thematic areas. Today, we're focusing on thematic area 2, which is widening access and participation for greater diversity and inclusion in research. So alluding directly to the strategy and thematic area in 2, we've had a very important piece of work supported and funded by the NIHR going back actually before 2018, but this is a little diagram to explain what we've been up to. Sean has been intrinsic to that work and Vicky more latterly, and we thank them for their contributions to this. So the NIHR Include Program that, as I say, goes back before our EDI strategy, was trying to consider how we could have better health and care through more inclusive research. And so the program went through 3 phases, starting to pull together a community of experts and reaching into stakeholder groups, looking at the literature around what underserved looks like in trials, and then bringing together communities in partnership to develop some guidelines, and then for those guidelines to be disseminated. So when we consider the work that was conducted, particularly the literature-based search around what underserved looked like in clinical trials, it was pretty fascinating, but not surprising, that in terms of who are underserved, there is no single definition. It's highly context specific. And the key characteristics of underservices, won't surprise you. It's about high care burden not matched by research. So something here also about underserved research questions, which may be the subject of future initiatives within the NIHR. And then looking at things like lower inclusion than expected from population data will not surprise you. And neglect how group responds or engages with research intervention. So these were key areas that developed from the literature. Barriers have been considered considerably in various elements of research. And in fact, some of the barrier works on barriers to research came out of the critical care literature from the UK. And here's a list of the kind of things that you would expect to see around some of the challenges of offering patients research and progressing that research. So probably no surprises. We put together, and Sean will remember this very well, the roadmap, which is kind of end to end, right from research priority setting, thinking about those underserved questions, all the way through to conducting research, getting the results out and disseminating and implementing, that the whole include opportunity exists along this pathway. And there is a Google site where you can see a lot more about the work that was conducted here and how we put the roadmap together in partnership with stakeholders and the public. We went on to start to produce guidance as this sort of crashed into pandemic, actually. So there were some real challenges about progressing this work, but there are various frameworks that were published, and Sean was heavily involved in those. And again, these can be found on the Google website. And there was inevitably something to be said about COVID-19, and Sean has since progressed the ethnicity framework, which he will probably mention later. And this is an old slide, more to come, which is why we're here today. So really looking forward to some of the next outputs that we're going to hear today. This is a very busy slide. You can find it on the Google site, but we're starting to populate now what this this pathway looks like, right from framing important questions, right at the far left of this slide, and lots of things starting to come into place around ethics committees, HRA, the funding decisions. Wellcome Trust have been very good at implementing some of these guidances. You can see Sean's ethnicity framework there, sat in the middle, and then out through GCP training, and increasingly looking from an NIHR perspective at data that helps us plan research around prevalence of diseases and its geographical distribution around the country. So lots of activity there. And finally, just to say thank you to the enormous number of partners that have been involved in the NIH Include program up to this point. And you're going to hear about more partnerships today. So if your organization isn't on that slide, it's a bit of an old slide, and we need to update that around new partnerships. So I thank you very much for listening to me. You can contact or look at our EDI team at the NIHR, which is cross-cutting at this website. There's lots of information there. And Sean, back to you. Thank you.
Thanks, Paul, and thanks for giving a good overview of the NIHR approach. I've noticed just in the chat there are a few questions about links that were on your slides, and I'm guessing, of course, there will of course be the recording, but I'm guessing we'll share slides too. Is that okay?
I'd be delighted, yes, and yeah, and Esther is also happy about that as well.
That's brilliant. So people will be able to get the slides along with the recording, so you'll be able to go to those links, and I can see that some links have been pasted into the chat. And again, just a reminder, if you have questions, then please do put them into the Q&A and we'll pick them up later on when we come to that session. Okay, so we've had the overview of the NIHR approach to EDI and inclusivity in research and why, and the work that it's done. What we're going to hear about now is the NIHR Include Impaired Capacity to Consent framework itself, and Vicky is going to talk to us about it. Thank you, Vicky.
Thanks, Sean, and thanks, Paul. So yes, I'm going to talk a little bit about the background to the framework, why it's needed, what's in the framework, how it's intended to be used, and some of the next steps for some of this work. There we go. So in terms of the sort of why we focused on this particular population, by way of kind of a background really. So over 2 million people in the UK have significantly impaired decision-making, and of course this can be associated with a number of long-term conditions, perhaps conditions such as dementia and disabilities, or may follow an acute event, or of course could be a combination of some of those. And of course, there are particular ethical and legal considerations when we think about conducting research that includes adults who lack capacity to consent. And this often means that these studies are quite challenging to conduct, and that frequently leads to their exclusion. And as we've heard from Paul, excluding populations from trials is quite a big problem. It leads to unrepresentative populations and issues around a lack of generalizability, as well as denying these groups the opportunity to take part in and to benefit from research, and also means that their voices and experiences are unheard. Ultimately, exclusion leads to this evidence-biased care, where we have evidence for some parts of the population and not for others, and contributes to a widening of the health inequalities that many of these groups already experience. And we know that the exclusion of people with cognitive impairment from trials is widespread, even in conditions, areas, populations where there are high levels of cognitive impairment in the target population. So you can see on the right some examples. So 1 in 3 patients with a hip fracture also have cognitive impairment, but this population is either excluded or ignored in 8 out of 10 hip fracture trials. And you can also see that some issues cross-cut across trials. So for example, 90% of RCTs are designed in such a way as to automatically exclude people with a learning disability from taking part. And even where they are included, they might be recruited or retained in a trial at lower rates than you would expect, and certainly lower rates than people with capacity are recruited. And that leads to this kind of consent-based selection bias, meaning the treatment effect could be reduced or obscured. And you can see an example there with stroke patients, where people who lack capacity are different to those who have capacity, and that can affect the results of those trials. We've heard from Paul around the increasing focus on ensuring research is inclusive of underserved groups, and that this is a key strategic priority. But to date, little attention has been paid to how we can improve the inclusion of adults with impaired capacity. We know that trials involving adults with impaired capacity are challenging, and many of you may already have that experience. And this was some work that I did as part of that consult project that Sean mentioned. And this was to explore what the kind of barriers and facilitators to research involving adults lacking capacity to consent are. So this was an interview study with a range of research nurses, trial managers, chief investigators. And kind of the three main themes were around the complexity of trials involving adults with impaired capacity. And you can see the quote there from a participant who described it as being like an unsurmountable black box of horrendousness that I dare not go, that it feels if you get this wrong, you'll be illegal and the ethics police will come for you. But also the importance of having access to appropriate support and resources. And this participant talked about how they had trouble finding information. It was like stabbing in the dark. Potluck Googling, eventually found information on the HRA website, but even when they used that information, then when they went to the REC meeting, they realized that it hadn't been interpreted correctly, or they had not thought through some of the issues. Participants also identified the need for greater knowledge, expertise and support. And you can see the participant here described what they thought of the idea of the framework that we put to participants, and how they thought that was a good idea. And that they talked about how participants lacking capacity are often excluded from the studies. A lot of people get to that box in the IRAS form and just tick no. But if we have equipoise and there may be benefits to the patients, then not having capacity should never be a barrier. So that led to us progressing with the development of the framework, and this is intended to help researchers overcome some of the complexities and provide some help and support and signposting to resources. So development of the framework was led by members of the TMRP inclusivity subgroup, and built on the Include initiative you've already heard about, and the ethnicity framework that many of you will probably already be familiar with. It was developed in conjunction with researchers working in relevant specialities, and of course with people living with conditions that may impair their decision-making and their carers. And it also builds on the consult work that we've already talked about. We started it back in 2021, and the development has kind of followed 5 main phases that you can see on the slide there. So the scope and content of the framework was established, and the ethnicity framework structure was adapted to be relevant to this population. We did a scoping phase, which explored the relevance of the framework to different populations who may have impaired capacity. And that was partly through consultation with specialty leads and with piloting of the framework in a range of different trials and settings. We then had a consultation phase where we explored the views of people living with impairing conditions and their carers about the framework, and to identify any kind of missing content areas. And we then refined the framework following all that feedback. And for the past 6 months, I've been working on a kind of implementation project, which is around the development of a kind of toolkit of resources to help research teams to use the framework. And that's part of what we're sharing today. So what is in the framework? So as I say, the framework is intended to help researchers who are designing trials to identify the methodological issues that their trial may encounter and to minimize the barriers to inclusion. It consists of 4 key questions for researchers to think about, which are broadly similar to those in the ethnicity framework. So there is some consistency across these various frameworks. But these questions here include which groups of people the trial results should apply to, whether any particular aspects of the condition or disability that the population have, or the intervention being tested, or the way the trial is designed will affect people's ability to take part in the trial. The framework, like the ethnicity framework, doesn't help you to answer question 1. That's more about looking at the kind of data and evidence, as well as people with lived experience, to kind of explore who should be included in the trial. Now, for each of those 4 questions, there are worksheets to help you answer the questions and identify what kind of actions and resources are needed. And the sort of areas that include are things like the eligibility criteria. So that might be whether they directly or perhaps indirectly exclude people with impaired capacity. Thinking about the accessibility of the trial information, whether that's in, for example, easy read format or pictorial versions. what the informed consent arrangements are, and of course, accounting for whether people might gain or lose capacity during their time in the trial. And then thinking about where and how data are collected, and perhaps whether they are accessible data collection tools, if they're being self-reported, whether they could be proxy reported or not. And then how the results are analysed. So for example, is subgroup analysis needed? And then how the results are shared with the groups. So we're often very good at having accessible information for taking part in a trial, but less good about thinking about how our summaries of results are equally as accessible. And then that final part at the bottom, you can see researchers can then summarise the actions and resources needed to ensure their trial is inclusive of those populations. So that might be whether additional documents are required, thinking about whether people lose or gain capacity during the trial, and also what resources might be needed. So for example, additional research time to ensure that people's ability to consent is optimised. Also included in the framework is an appendix that has this summary of the legal frameworks to help you kind of tease out what that might look like in practice. And of course, it varies between the types of research and where in the UK and beyond it's being conducted. And then lastly, it signposts to a website of collated information, and that's the Consult website, where you can find lots of information and resources. So for example, around how to assess capacity, how to develop accessible information. So the kind of key messages around how and when the framework is used. So it's intended to be used for all populations where there may be issues around capacity, but of course it will vary between different contexts. Not all questions may be relevant and they can be left out if they're not particularly helpful to you. It's intended to be used specifically for trials, but it might be useful for other study designs, especially that question 4, which talks about study design in more detail, and the kind of worksheets to help support that. It should be used ideally at the earliest stage, so when you're thinking about applying for funding, but it can inform the kind of later development of a trial as well. So particularly when you're developing a protocol and an ethics application. And particularly around the ethics application, it might help you justify why you're including participants who lack capacity, and to justify the appropriate consent model that you've chosen. Importantly, it should be used collaboratively across the research team. It's not the responsibility of just one person. And of course, most importantly, this should include public contributors. And it may be that the questions posed in the framework kind of form the basis of discussions that you then document some of those with the outcomes and actions in the framework, rather than thinking of completing the Word document as the kind of end in itself, if you like. And when we think about who the framework might benefit, of course, it may take additional time and work at that early stage, but using the framework, we think will benefit researchers by improving the quality of their trial, the quality of their funding application, and of course, to ensure that the trial is well designed and inclusive of these populations. We think it'll reassure research ethics committees that the trial has been appropriately designed to include adults lacking capacity. And most importantly, it'll ensure that people with capacity affecting conditions or disabilities can participate in and benefit from research and ultimately receive evidence-based care in the future. And then just briefly to touch on the toolkit that we've developed to accompany it. This is, you can see on the screen, it uses kind of layers of information from raising awareness, which are the ones on the left-hand side, which are kind of infographics and a video that we'll show you in a moment, through to we've developed accessible information, and this has been co-produced in an easy read format by Thinclusive, who specialise in co-producing accessible information, and that introduces concepts such as capacity, consent, clinical trials, and then talks about describing the framework and how it can be used. And then there's a more detailed user guide, and we've also developed a library of completed frameworks in different populations and conditions and settings. And the plan is to build on this so that if there are particular areas of interest, particular types of trials you would be interested in, please do let us know. And I'm going to show you the video that we've produced. So if I can ask for that to be played, please.
Clinical trials help us find the best way to provide care for people by analysing the effects of different medical treatments. Sadly, however, the participants in these trials often do not reflect the populations for whom the treatment is needed or where it will be used. One underserved group in particular are people who are unable to provide their own consent to take part in a medical trial. This may include people with long-term conditions or disabilities, fluctuating capacity, and acute or critical illnesses. It is important that the trials include these groups, especially if they are likely to need or receive the intended treatment. This would ensure that the results are more applicable to the needs of these people and provide them with the opportunity to take part in and benefit from future research. Researchers tell us that designing trials to include these groups can be challenging, so we have developed a new framework to help address these issues when planning a trial. The Include Impaired Capacity to Consent framework contains 4 key questions for researchers to think about, including who their trial results should apply to and whether any aspects of the trial design itself will affect their ability to take part. There are worksheets to help researchers answer each of these questions and identify what actions and resources are needed to support their inclusion. This might include the eligibility criteria, accessible information, appropriate consent arrangements, data collection, and even how the results are analysed and shared. This framework should ideally be used at the funding stage, but also helps with the protocol or ethics application of a trial in development. Using this framework is a team effort, and it is vital to include public involvement contributors. Together with other tools, the framework will help ensure clinical trials are more inclusive of people unable to provide their own consent. To download the framework and find other resources, visit www.capacityconsentresearch.com.
Thanks very much. I can go back
Okay.
to the slides.
Back.
Sorry, Sean, just there's another couple of slides, but
That's what I thought, yeah.
fabulous. So I'll just quickly show you where you can access all this information. And again, we'll put a link to this in the chat. But the video, all the materials and the framework and those library of resources are all available on that page on the Consult website. You can follow the QR code, and also a number of other websites will signpost to that, including the Centre for Trials Research, TrialForge, and the NIH Google site that we've already heard mention about. Just quickly to acknowledge and thank everyone who's contributed to this work, whose names you can see on the screen, and of course the lay advisory group of people with experience of living with and caring for people with conditions or disabilities that may affect capacity to consent, along with this inclusive advisory group, and of course to the funders. In terms of next steps, as I say, you can download the framework, those materials, and there will be a recording of the webinar all available on that webpage. We'll also be sending out a brief survey after today's webinar to kind of capture your feedback and reflections. So if you have any questions after today, please do put those in there, and we can help collate all those into a FAQ that will be on that website as well. There's also an opportunity to receive help to use the framework. So we're offering a kind of online individual discussion to talk through how it applies to your particular trial. So do get in contact. And also we'll be doing some further work to support the use of the framework and to evaluate it as well. And then just to briefly mention other work going on around inclusivity. So there's a kind of sister framework as well, which is the socioeconomic disadvantage framework about to be launched. There'll be a similar webinar on the 24th of January for that, and we can put a link to that in the chat. And then other work around LGBTQ+ communities, inclusion of care home residents in research, and then also work focusing on the kind of intersectionality aspect and how we can bring these various Include frameworks together. We'll just quickly end on my contact details, so please do get in contact if you have any questions after today. And I'll hand back to you, Sean.
Thanks, Vicky. So Vicky, that's a fabulous overview. And just to emphasize that there is that website with lots of resources to support what you've heard Vicky talk about today. And the link, I think, has been sent out in the chat, and it'll certainly go out afterwards by social media, etc. We have a lot of questions, so I'm just going to dive straight into them. And I think most of the questions would be something that both of you could have a stab at, would be my thought. But in the interest of time, we might just have one answer to each of the questions. So let's start and see how we get on. So this is a question from Annika, and the question is, for a non-CTIMP study, how would you approach people who may have impaired capacity to take part in the study? And there's a little bit more detail with that one. So for example, people living in a care home who may or may not have dementia, and where the severity of dementia may be on the extreme of the scale. So how would you approach people who may or may not have, I guess, impaired capacity?
Yeah, shall I answer that one?
Yeah, Vicky. Yeah.
So we haven't talked too much about capacity because it's obviously a huge topic, but essentially there's a principle where capacity to make a decision is assumed unless there is evidence otherwise. So I think whenever you would approach a potential participants, for example, in a care home, you would assume they have capacity. And then obviously speaking to care staff, speaking to the participant themselves, possibly their family, might be where you try to understand a little bit more about what their communication needs are, but also whether there are any concerns around capacity. And if you have concerns, that would lead to a formal capacity assessment. But we do know that, for example, 70 to 75% of care home residents probably lack capacity to consent. So any trial you're conducting in a care home, capacity is going to be a really big part of understanding how you're going to kind of design your study and approach people. But yeah, approaching the person, involving others in that process, and then ensuring the trial is designed to be inclusive of that group.
Thanks, Vicky. I think this next question is probably also best answered by you, Vicky. This is from Carol. Just wanting to check that the framework covers the legal issues for Scotland, which may be different to those in England and Wales, or perhaps it doesn't matter.
So it is intended to cover any area. The appendix that I mentioned summarises the legal frameworks in England and Wales and Scotland, so you can see what some of the differences are. But for example, emergency research, non-CTIMP, isn't currently allowed in Scotland. So it won't help you address that problem, but it will help you kind of think through some of the issues. And I think maximising the kind of inclusion of people might enable that threshold for whether people are able to provide their own consent or not to be raised. So if your information is accessible, if you support people to make a decision, they might be able to provide their own consent, whereas previously they might not have been able to. So yes, applicable to all, and the legal framework differences are teased out a little bit in that appendix.
Thanks, Vicky. And this next question, I think, is probably for you, Paul. This is from Mary Claire. And Mary Claire has said, so when listing barriers to participation, Paul didn't mention mental health or cognitive impairment as a barrier, but clearly both are, and perhaps sometimes more than physical impairment. Did NIHR consider those characteristics as well?
Yeah, thanks, Sean, and thanks, Mary Claire. I mean, the areas I was alluding to was about what was prominent in the literature and with some stakeholder groups. The literature, very interestingly, was overwhelmed with North American studies. From what I remember, Sean, there was actually very little from the UK. I was on the committee actually from the perspective of patients lacking capacity in emergency care research. So you can imagine I was quite vociferous. But in terms of a balance of today, I focused on what were the main points that came out of the literature searching and some of the stakeholder groups. But you can be absolutely certain if you look on the Google site, capacity issues are very prominent. Thanks, Sean. Thanks,
Paul. This is a comment stroke question from Anne, but it was something I probably would have asked you about as well. And it's the term that one of I think the people you spoke to used, which is ethics police. And so Anne's saying, you know, I'm on an ethics, I'm one of the ethics police, that's what Anne's saying. So sitting on a research committee and don't see their role as policing, but trying to get the research up and running in an appropriate and ethically acceptable way. And clearly sometimes researchers don't manage that, but they wanted to work with you. And I wondered whether you had comments on that, in particular that ethics police and that view that there is policing, and where that person was coming from when they raised that point.
Yeah, thank you. That's really interesting. So I similarly sit on the ethics committee, so might also wear the police hat, I guess, in theory. But I think it's about that perception, isn't it? That because there are legal and ethical issues, it's people's fear of getting that wrong that leads to exclusion, that it just feels so complicated and the potential implications so huge that people shy away from including people who lack capacity to consent. So I don't think, ethics committees are in that kind of role. And we also are kind of learning more about how we can support inclusion when we review studies. But it's essentially around that fear of getting it wrong that participant was speaking about. And that was a participant who conducts care home research. And we've already mentioned what the proportion of people who lack capacity. So if you're conducting research in that setting, but are so terrified of getting it wrong that you exclude anyone who lacks capacity, your study is probably not going to be represented, and certainly people living in care homes are not going to have the kind of evidence that they need.
This is the next question is from Alison, and I think this is probably a question aimed at you, Paul, which is there a commitment from funders to provide additional funding to enable researchers to include all populations who may benefit from that research?
Well, I can speak on behalf of most of the public sector funders in the UK, and it's worse than that actually, because now you will be assessed at application on your ability to respond to the needs of the population that you're researching, what underserved looks like and how you're going to tackle that. And that will, for some funders, some funding groups, that will be a separate assessment issue. So there's a lot of forcing functions here. And of course, the funding that you request in your trial will meet your aspirations to include the breadth of patients that you intend to do so. And frankly, from an NIHR perspective, you'll be held to account from that perspective.
Thanks, Paul. And that's my experience too from the NIHR side, is it will certainly become very difficult to not discuss how you will include individuals who could benefit from the intervention, and when well justified, you're going to get the funding. There's an expectation that you will do it, and that will certainly require resources to do that. There are a couple of questions here from Colin. So I think one of Colin's questions about legal provisions, I think Vicky, you've already talked about that. But the second question is, and it's probably aimed at you, Vicky, is did the development of the framework take account of the provisions in the UN Convention on the Rights of Persons with Disabilities?
Yeah, that's a really good question, and again, quite a huge topic. But essentially what we talk about is that the principle that groups should be included unless there are really good reasons why they shouldn't be, I think picks up on that idea of that people with a disability should have access to services, to research in the same way that anyone else who doesn't have a disability does. So it certainly adopts that kind of principle. And the idea that supported decision making is what we should be focusing on. And then if that isn't possible, that kind of surrogate decision making where you involve consultees or legal representatives. So it certainly puts that kind of focus rather than just, okay, people lack capacity, so we'll kind of override and get someone else involved. So it tries to take account of that kind of principle and the kind of reasonable adjustment idea that we're used to in other kind of settings, but don't necessarily think about from a research perspective. So when we think about accessible information, we're more comfortable thinking about, okay, perhaps we need to interpret information sheets into a language that's not English, without really thinking about, okay, what about creating accessible versions, easy read versions, pictorial versions, layering the information, making it more accessible to anyone really. And that's where we've worked with Inclusive to develop the accessible guide to the framework, but we should probably be doing that for pretty much all our studies. If they're routinely excluding people with a learning disability, why are we not making all our studies accessible for those populations and for others?
Thanks, Vicky. And that actually was one of the statistics you presented, or maybe it was you, Paul. I think 90% of trials exclude people with learning disabilities. Really a very striking statistic.
And when we think about what the difference is in terms of life expectancy for people with a learning disability, there is a link between health inequalities and research inequalities, and we need to do a lot more to level that up. Yeah.
Excellent. So we've still got lots of questions, so let's see if we can get through some more. So this one's from Julie, and either of you, maybe Paul, it talks about critical care research, but a lot of work has been done regarding consent in critical care research trials where almost all participants will lack capacity. For example, the deferred consent model, the use of consultants, etc. Has this been integrated or used to inform the work for Include?
I'm sure it has, because Vicky reached out to us as a national specialty group in critical care and in emergency care over the period of the evolution of the project, and we had an excellent opportunity to feed back our current models that are expected by ethics committees in the various jurisdictions. So whether that be CTIMP or non-CTIMP studies. So I'm sure it does, Vicky.
Yeah, and probably just to add as well, my background is critical care nursing, so it's something I'm kind of very familiar with. So yes, it does, and that's where that kind of applying it in different kind of contexts. And I think there was a comment or a question around whether it applies to research without prior consent and where you might involve CAG approval. So it's the kind of high level questions that help you dig a little further around that and then think a little more deeply. So studies are frequently designed to use that kind of model, but then perhaps don't always think about, okay, what if a participant dies prior to gaining their consent or from a relative? What do we do then? Do we inform relatives? How can we use their data? What about opt-out questions? So it encourages you to think through those issues ahead of kind of encountering them further down the line, I guess.
Thanks, Vicky. And I can see a related comment actually from a person who's currently anonymous, but it says, how does the new framework differ from the current deferred consent model used in critical care research? And I guess the point is that that is part of what the framework is about, but it is much broader than the actual consent, just the consent process.
Yeah, exactly. And, it encourages you that even if you're using that model, and we see it not infrequently in the ethics committee, that people using that model still then have a 14-page participant information sheet for people who are just recovering from a critical illness or cardiac arrest. So even when you're using those models, there are still things to think about how it can be accessible, how it can be inclusive. And then, as I mentioned about, analysis, but also about providing results summaries and things. So even when you're comfortable using those models, there is always more that you can think about in terms of making it accessible end to end, as Paul mentioned.
Yeah. Here's an interesting question. This is from Stephanie. Should we start including underserved populations in feasibility trials? There's two nods there, so enough said, perhaps. So I guess the idea is yes, we would, and I would agree with that too, that we all need to think more about who we include in our trials, whatever type of trial we're doing. And I would say very early trials, you still need to be thinking about who are the people we need to involve in this early stage trial. May be different from the late stage, but we still need to think about who we should be involving.
Yeah, and beyond that as well, thinking about when we're developing outcomes, for example, and then if we're looking at acceptability and feasibility, because it may well differ between these underserved groups. So yeah. Stages, all types.
Indeed. And next question, this is probably aimed at you, Paul. And this is from Siku. And will there be a way to see or ensure that trials are indeed embedding EDI in their trials, like some form of accountability on the part of trials? And who will be making sure that this is followed?
Oh, that's a great question. And by the way, Angela, I can see that you've asked me to speak up, so I apologize. I hope you can hear me okay. So yeah, monitoring our ambition at the NIHR is crucial. We have produced 2 data reports, one in the one in the previous financial year, and one that you will see was published over the last 2 weeks I'll see if I can find the link, Sean, and put it in. That is very much about our workforce, our committees, and who we fund. But the last data report started to look at this whole issue of our EDI within our funded trials, and there's some statements there about HTA trials. So we are looking at our data streams to make sure that we capture key evidence for implementation of our policies and strategies, and we're going to hold ourselves to account, because if those data show that we are not making any impact, then we need to learn from that and change. So it's we're not saying that our strategy is something that we talk about and is a sort of a dead, unliving document. We've got to continually review and refresh and learn, and I think that is the same in trials as well. We held very good data around portfolio, NIH portfolio studies on the open data platform, which many of you will have access to. And we're looking at the kind of data feeds that we need to improve upon to make sure that we hold ourselves to account. But that's data. And as Esther will remind me, it's always about context. So the qualitative kind of work as well that will underpin understanding of those data is going to be really important.
Yeah, indeed. Thanks, Paul. So the next question we'll go for here is one from Amanda. Amanda says, I do a lot of observational work in diagnostics, and I wondered how you balance the benefits to others, so societal benefits, against the fact that the individual who has impaired capacity will not or may not benefit themselves. Is there a balance to be struck with? What do you think? Vicky, perhaps?
Yeah, absolutely. And of course, that's what the legal frameworks talk about when you have to justify why you're including people who lack capacity to consent in research. And of course, that's very different from all the other underserved groups, where the principle is you include people, but there is this legal requirement that you have to justify why you're including these populations. And it is all about the, will there be direct benefits for others with similar conditions, balanced against the kind of risks and burdens that the participants may experience from taking part. So absolutely, there is that kind of balance, and say that the legal frameworks talk a lot about that. And then it's how you interpret that and how ethics committees interpret that it can get quite tricky. But yes.
Yeah, and I have seen just in the chat that there's obviously been an exchange of people's experiences in trying to involve people with impaired capacity, and it certainly hasn't always been easy. And then perhaps the Include framework and the initiatives from NIHR will help to change that. It'll make it easier to justify why it is important to involve individuals or make a case when it is particularly important. Okay, well, we are running out of time for Q&A, but we will get a couple more questions in. So here's one from an anonymous questioner. Is there guidance for working with relatives of potential participants, people who may have power of attorney? Vicky, is that one that you might be able to answer?
Yeah, so the framework doesn't include that kind of guidance, and it is kind of lacking. I guess the closest place is the Mental Capacity Act Code of Practice that talks a little bit about that. And there are interesting questions about power of at-torney versus the arrangements for research, which don't include power of attorney. And particularly some of the work that I've just recently started around, can we encourage people to do advanced research planning? So in the same way that we think about advanced care planning and appointing a power of attorney, can we encourage people to talk and express their research preferences should they lose capacity, and who they would like to act as a consultee or legal representative? Because currently all that is retrospective. We only think and talk about that once someone has lost capacity. So no guidance out there, but lots to kind of think and work on, I think.
Okay, and this is going to be the last question, and it's a really interesting one, probably aimed at you, Paul, and it's from Abby. And Abby's saying, I wonder if another barrier for researchers is the constant message that we need to be more efficient and do research more quickly and for less money. So resources sparse in terms of CTU staff, etc., lots of extra work, and with the checking of regulations, etc., lots of longer time. And we also have to make our studies easy and attractive to healthcare staff as well. So there's tension between a message of faster, cheaper, more efficient, etc., and the sort of additional work that inevitably will come from what we've been discussing today.
So I would argue that efficiency in trials is completely consistent with what Vicky has produced here, and that our ability to recruit patients who are potentially going to benefit from interventions, and that was touched on in Vicky's presentation, we probably need to reorganize our thinking and work streams that allows us to do this better. And I think that will produce actually efficiencies. We will see a greater opportunity for the impact of research. And we will adopt these principles in a way that streamlines outcomes that are relevant to patients, et cetera, et cetera. So I think there is a consistency in this. It's always in a period of transition and challenge where we have to consider how we're going to adopt these, that it feels a bit insurmountable. But I absolutely think ultimately this is consistent with efficiency.
Yeah, I mean, I would agree with that. I think it's a great question. I've heard it many times in other contexts as well. I think it is all about thinking about the utility of the research evidence and the impact it may have. That's the efficiency. We're doing work that leads to a result, and results that are more useful than they would otherwise be. And I think that is the big efficiency. Notwithstanding the points you make, Abby, I think you're absolutely right. We've all recognized those challenges, but the efficiency argument is greater, more effective use of research evidence. So I'm going to end the question. We have loads. I mean, we could have gone on for another hour, I think, on that. What I will say to people who've asked questions is that the Q&A and the chat will have a recording of that. So I don't know whether the plan is to share any of it, but what it will do is influence how we talk about this in the future, what the process is like. So we always keep the chats because they do make us think. We know what questions people have, and even if we haven't answered them, we will reflect on them and try and make sure we answer them in future presentations, or indeed in the materials we produce. But what we want to do just before we end, and we will finish on time, is do that last poll. So as we saw earlier on, lots of people had what my dad would call fair to middling knowledge, and we wondered what people's awareness is now, having listened to the discussions and had the Q&A. So we'll just spend a minute or so on that. Okay, let's have another 5 seconds or so, and then we'll see what people have said. Okay, let's close that one and see whether there's any noticeable difference. Okay, so that's just, to me, just looking at it visually, that's quite reassuring. It has been a bit of a move. It's not quite so spread. So I think that's good, and more at the higher end. So I think it's been, we've got some quantitative visual image there that this has been a useful session. It's improved awareness. Still work to do. Obviously, we'd like everybody up at the top end. But that, I'm really quite pleased at having seen that shift. So thank you for your attention. A couple of things right at the end, just to end. As we've said before, we've got contact details here that Vicky has put up. There is that website, the one at the bottom, that will give you lots of resources, the sorts that we've been talking about today, that Vicky has been talking about. And happy to take questions. You can see some contact details there for further information if you would like it. That recording of this webinar will be available probably today, so we'll get that quite quickly. And then just to flag again, that in January, there will be a webinar similar to today on the socioeconomic disadvantage framework. So another Include framework there to make you aware of what we're doing there as well. And I think you will get a survey and evaluation questionnaire to give a bit of feedback. So if you do have a few minutes to spare, then please do fill that in. But I'll end with thanking everybody, obviously all of our audience, and for your time and attention, and in particular to Vicky and Paul for your presentation. So thank you very much for your time, and thank you very much for your attention, and hope you have a great day. Thank you very much.
Thanks all. Thank
Cheers.
you. Thank you.
Bye-bye.